This is where the most critical cases are managed. Those whose bodies no longer respond to ordinary drugs.
For patients who have resistant TB, we do what they call ECG, electrocardiogram. It is a test, an equipment that we use to monitor the heart rate. It monitors the heart, how the heart rate is, and we do it for every patient. This is our in-charge nursing officer. He's called Ndema Moses. Yes, he's going to perform an electrocardiogram on one of our patients who has resistant tuberculosis. Like I said earlier, this machine, it measures the electrical conductivity of the heart, and therefore we are able to capture the heart rate. And if the heart rate shows that it is rapid and abnormal, then we stop that drug and monitor the patient and give another drug if it is the drug causing the heart rate to be abnormal. So this we do for every patient every month when they come to visit.
For every patient?
Every patient.
On every visitation?
On every visitation. So in fact, like they say, drug-resistant TB management is largely about managing side effects of drugs. Because the drugs, fine, they kill the TB germs, but they are very toxic. And one of the things we look out for is toxicity to the heart. And therefore you must monitor the heart every month at every visit to ensure that the heart functions normally to enable us to continue treatment. Because if you don't monitor the heart, the patient can develop an arrhythmia, an abnormal heartbeat, and can lead to sudden death.
Which is very sad.
Which is very sad. And I can say we have never had a sudden death. Yes, because we monitor patients.
Right.
Yes.
That is good statistics.
Yes.
All right. Do we have instances where individuals out there and have not been referred to this place where the monitoring is that close to mild, you called it mild drug resistant?
TB, yes.
TB? Yeah. Do we have cases where individuals come when it is already too late and there is no any type of medication that can cure them anymore?
Yes. We had a case referred from Masaka Hospital early this year. The patient had had TB for a prolonged time, undiagnosed, and the TB had destroyed the lungs completely. By the time the patient came to us, there was almost no lung tissue for gaseous exchange, because you know that our lungs are very important to ensure that oxygen enters and carbon dioxide gets out to give the body energy for it to be able to talk and walk and eat. So once the lungs are damaged irreversibly, once the scars form, they don't go away. So she had irreversible lung damage, and despite giving her TB drugs, and actually her TB actually was improving, but because of the irreversible lung damage, the patient now died of complications of TB. Yeah, so the TB can cure, but because of the extensive lung damage, the lung function can never return to normal. Yes.
Now, in cases where the drugs have presented very horrible side effects, like the increase in the heartbeat, as you already told us, what is done?
Yes. So once we do the ECG test, it comes out. For example, this test has come out. The ECG, it tells us the electrical conductivity of the heart, and we see that the heart rate is abnormal. We do 3 of them in a row to confirm that actually it is true. Because sometimes the position of the patients you might to be sure we do 3 of them. Once they're all consistent, okay, we also do other tests because we don't blame the drug before we rule out other causes of the abnormal heart rate. There are conditions that can cause abnormal heart rate, like low levels of mineral salts in your body, low potassium, low calcium. They can cause abnormal heart function. If your thyroid is not functioning well, it's called hypothyroidism, you can get an abnormal. So we rule out other causes. And once they are ruled out, we now say it must be the drug. It's called a causality assessment. So once we know that it's down the drug, then we stop the drug and get another drug. It's called drug substitution, to show that the patient continues without this drug, which is causing a harm to the patient's life.
Every heartbeat, every blink, every breath is watched and recorded because one missed sign can mean the difference between recovery and relapse.
So this is one of our nurses. She's called Daisy. She's going to take for us a visual acuity of this patient. We do this to monitor, so that if there is a visual loss and we catch it early, we stop the drug and change the drug to avoid permanent blindness. For patients with MDR-TB, to complete assessing one patient, we need 1 hour just to see one patient. When they come for review, we ask them for their symptoms, have they resolved? Then we take their weight. Then we take their ECG.
But innovation has found its way even into drug dispensing. These electronic containers are equipped with artificial intelligence designed to monitor patients' adherence.
So this is the counselor's room, where in TB we pack medicines for patients. These are called electronic pill boxes. They're electronic, so we pack drugs for because the drugs, as you can see, tablets are many for MDR-TB. They are five tablets they take every day. So we ensure that we pack them for them daily. But when they open it, they take it per day. And and this is put in a box. This is called the electronic pill box. So we pack 30 of these, 4 of these for a month to make 30 days. So each time this pill box, each time a patient opens it, it sends a signal onto our dashboard where we shall know that the patient has opened the pill box, and we assume that the drugs have been taken.
Right.
And therefore, if a patient does not open the pill box, we call the patient after 2 hours, and then to remind them to open their pill box. And that's how we have managed to ensure that patients adhere to their treatment every day. We do electronic monitoring of their medicine taking every day. And if they don't open their pill box within 2 hours after 9, we call them to remind them to take their medicine. And then the recording is taken that the medicine has been taken. And because of this, we have improved our treatment success rate. So out of every 100 patients who initiate treatment in our facility, 90 of them get cured. So 9 out of 10 get cured because we monitor that the drugs are taken on a daily basis. And the magic takes place here where they pack for every patient medication and fill their pill box for a month.
Right. Does distance matter? Like even
it's electronic. So as long as there's network, the signal is captured. So we have a tablet at the center, and we have social workers who monitor every morning the patients if they're taking their drugs or not.
For the first time, machines are helping ensure human discipline, making sure every pill counts. At Mulago, healing goes beyond the prescription. Nutrition plays a central role.
Omuntu alya ku kanyama, anywa ku mata, anywa ku porridge oyo omukole. Akatooke era okalaba kaba kanyirira. Kati omuntu atuuka naga ne bwe bansiibula wakiri era bangi basaba abasawo basigale.
Mbeeza buli kika nazo bazituwa. Empuuta, ennyama, enkoko, n'emmere amatooke, muwogo, byonna buli kalaane batuwa n'ebyokunywa.
Nebaza nnyo abasawo batulabiridde bulungi. Batwongeremuko, twagala kulya ku nkoko bikoko ebyo okumala nga wiiki. Tuddeko wiiki tulyeyo kijanjaalo ekyo.
For many, this is a second chance at life, given freely, compassionately, and without cost.
All patients who are admitted with the drug-resistant TB are able to have cooked meals, breakfast, lunch, and supper. And we give a balanced diet that includes the fruit, vegetables, proteins, and carbohydrates, as you can see.
I'm impressed, doctor. I'm honestly impressed.
Many of my patients will say that even at their homes they don't eat like this.
Yeah, he has already confessed.
And some of them will ask me not to discharge them even when they are better. Yes. And sometimes I have to explain that they must give other chance also who are ill so they can get better with the same food. And sometimes it's difficult to discharge, more so the male patients.
Beyond the daily fight, Mulago's TB department is shaping the next generation of experts, training, innovating, and researching for a TB-free Uganda.
Here we have Dr. Jumba is a medical officer, and we also train interns. Like I told you, in Mulago Hospital, we are also a training institution, so we have also an intern, Miliary. The medical officer ensures that the intern learns everything about management of TB, so they work side by side, one-on-one training, as you can see.
In the words of Mulago, every breath counts, every patient a victory. From fear to faith, from illness to hope, this is where Uganda's fight against tuberculosis is being won.
Our patients, some of them are homeless people. For example, we have a patient who's a street child. He has no family support. He has no home to go to. So such patients, I admit them on my unit and give them TB treatment and also give them food. Now, what motivates them to stay on the unit is the illness. When patients are very ill and they have chest pain, they have cough, and they have difficulty in breathing, and they are very ill, they are more likely to accept a treatment. And therefore, patients will accept to be admitted. However, when they take treatment, eat food and get better, some of them can actually get lost to follow up. They stop taking drugs and disappear in the community. That is why for patients such as street children or homeless people, I will keep them on the unit until they complete their treatment, because the unit is now their home. It is their support system where they will eat food and also take treatment.